Good morning, everyone. My name is Dr. Wayne Terrace, and I'm the Chief Medical Officer of Care Compass Network. Welcome to the first annual Partnering for a Resilient Community virtual learning. This dialectic behavioral therapy workshop is sponsored and supported by the Care Compass Network's Regional Trauma-Informed Care Network team. The team consists of dedicated and passionate individuals from colleges, county government, healthcare, social care, human services, and schools spanning across Care Compass Network's 9-county region in the Southern Tier and beyond. The Regional Trauma-Informed Care mission is to implement evidence-based trauma-informed care by supporting the development of resilient and strong partnerships, individuals, families, and communities through advocacy, education, and empowerment. A core strategy to bring this to fruition is to create and promote access, availability of training, educational tools, and resources for our community. The team envisions a resilient community built upon strong partnerships, trust, and compassion. Before we get started with the presentation, I would like to go over a few housekeeping items. Today's presentation will be recorded for quality assurance purposes and may be uploaded to CCN's website or YouTube page. There is 5 minutes reserved for Q&A after session 1 and after session 2, and 10 minutes at the end of the presentation. Please type your questions into the Q&A box, which is located on the bottom of your screen. You may send in your questions at any time. We will be collecting these and addressing as many of them as possible. Now I would like to introduce our presenter. Nicole Paterson Babcock, LCSW-R, has been working in the human services field since 2001, with extensive experience working with children, adolescents, and their families in a variety of capacities, and has been a provider of mental health counseling for adults since 2013. She was introduced to DBT while working with adolescents in a day treatment program and led a DBT skills training group for adults during her time at UHS Outpatient Mental Health. Later, Nicole was extended the opportunity to spearhead the development of a comprehensive standard DBT program at Lourdes Center for Mental Health. She and a small team of clinicians from Lourdes completed the DBT intensive training, an extensive and highly involved training process through behavioral tech in January 2018 with support from the Care Compass Network. Nicole served as the team lead for the DBT team at Lourdes and successfully graduated 2 groups of patients from the comprehensive DBT program for adults, as well as providing team consultation for the successful graduation of 2 adolescent patient groups. She has participated in clinical and program phone consultation with a trainer through behavioral tech for the past year in order to further her practice, also with the support of CCN. Nicole has recently begun full-time private practice through her Validation Counseling Services, LCSW-PLLC in Binghamton, where she plans to offer both DBT-informed treatment and comprehensive standard DBT. So Nicole, I'll hand off to you and we can proceed with the presentation.
Thanks so much, Dr. Terrace. I am so excited to be here with you all today. This training has been a long time coming, and I know many of you are aware that it's had to be postponed several times due to the pandemic. So I'm really glad to be talking with you all today. I'm especially excited to be here to talk about DBT today, not only because it's been a game changer in my practice with my own patients and has allowed me to reach and help people that traditional therapy was not working for, but also because I know firsthand how difficult it can be to access full comprehensive DBT training, both because of financial, time, and individual barriers. And I wanted to share some of the things that I find most helpful about DBT that I feel can still really benefit practice even without a full training in DBT. So I'm excited to be with you today, and I'm hoping that you can take something away from this training that can help you and your patients moving forward. I'm hoping that each of you has had a chance to look at the audience poll. I wanted to start the training just discussing what the level of exposure is that each of you have had to DBT going in, just so that I'm gearing the training toward the experiences of the audience. And I'm wondering if we have poll results at this point that we'd be able to talk about. All right, so it looks like about 59% of those of you out there right now say that you're familiar with some of the skills and strategies, but not much else. And then we've got a fairly even distribution that, you know, some of you are just aware that DBT exists and that's it. Some of you might have read some of the manuals or attended at least one formal training in DBT. So fairly wide distribution, but being aware that some of you are aware of some of the skills and strategies, I think is helpful for me as we move forward. So thanks for taking a look at that poll. Let's see. So getting started, I wanted to talk about what DBT is and why it matters in practice. DBT is an evidence-based practice. It has been researched pretty extensively with a number of different patient populations, ranging from children through geriatric populations, and populations with a very wide variety of disorders. DBT was originally developed to treat patients who had acute suicidal behaviors, and also chronic suicidal behaviors, as well as self-injury. And it was later discovered that the majority of those patients did meet the criteria for borderline personality disorder. Although DBT was developed to treat that population primarily, it has been found to be effective for a variety of populations, as I said, ranging from children, adolescents, older adults with chronic depression. There's a growing body of evidence for DBT in substance use treatment, as well as eating disorder treatment, and can be helpful on a number of different levels, which we're going to be talking about. There are currently DBT trained programs all across the world. There are many different countries offering DBT, and a pretty wide variety of research out there if you're interested in looking into that further. I would certainly encourage looking at the website for behavioral tech. Behavioraltech.org offers a number of different resources for looking at evidence-based research on DBT. DBT is a model that offers skills, structure, and support for both patients and clinicians, which is really important when working with patient populations that are especially challenging to treat and patient populations who are really struggling. It utilizes strategies that are designed to engage patients with complex problems. And we'll be talking more about examples of those types of situations as we move forward. I will also say that although that is what DBT is designed for, many of the skills and strategies from DBT can also be helpful in patients who don't have super complex problems. And many of us who are trained in DBT, myself included, use the skills and strategies themselves every day. I personally really enjoy using the DBT skills and find them very helpful in my personal life. So, you know, keeping that in mind as well, and keeping in mind that making sure that the things that we're teaching our patients are things that we would use ourselves is really important. DBT is a multifaceted approach, and we're going to get in just a minute into what each of those different strategies for DBT are, but it is a complex therapy for treating complex problems. And the structure of DBT can be helpful in reaching patients who aren't helped by other forms of treatment. When I got started treating patients in a clinic setting, CBT was what I was oriented to. And CBT can be really helpful to a lot of people. And CBT can also be an approach to treatment that can feel invalidating to patients who don't trust themselves or their emotions. Especially when there are situations where they're being told that maybe their thoughts aren't accurate and they need to think about things differently, which can lead to difficulties with engagement and eventually dropping out of treatment for people who really have problems that are complex and intense. So there are a number of different types of DBT that are really important to be aware of. And when people talk about DBT, they may be talking about different things. So getting clear about what DBT is and what type of DBT someone might be referring to is really important. Standard evidence-based DBT has 4 components. It has a high level of complexity and it requires extensive specialized therapist training. Individual therapy is offered once a week for approximately 1 hour, and skills training is typically held in a group format in standard DBT. And in standard DBT, skills training is held anywhere from 2 to 2.5 hours in the evidence-based model once per week. Phone coaching is available 24 hours a day, 7 days a week to participants in order to help them generalize the skills that they're learning in skills training and individual therapy to broader settings and to situations where they need them in order to increase safety and improve progress towards their goals. A therapist consultation team is the last and certainly not the least part of a comprehensive DBT program, because support for a therapist and support for adherence to a complex and challenging model to implement is really important in being able to provide effective treatment. When we refer to evidence-based DBT, standard DBT is typically what is being referenced in those circumstances. When many people think of DBT, they think of the DBT skills, of which there are many. I think at last count in the standard DBT protocol, there are somewhere between 52 and 54 DBT skills. There are a lot. So the skills are a piece of DBT that has been really popularized and that can be really, really important in helping to move people forward in treatment. Skills training only is an approach to treatment that is growing in evidence. There are increasing numbers of studies that reflect the effectiveness of this mode of treatment. And it's usually offered in a group setting in combination with a therapist consultation team. Less extensive therapist training is required for this model, but specialized training in running a DBT specific group and being really familiar with the DBT skills is also really necessary for a skills training only program. DBT-informed treatment, which is what we're going to be discussing much more extensively today in the rest of our training, is an approach to treatment that uses a combination of DBT skills and individual therapy strategies from DBT. It may lack some of the foundational components of standard DBT, which can be really difficult to implement in a lot of different settings, especially in an outpatient setting like a clinic or a private practice, where access to a therapist consultation team or 24-hour phone coaching or even a group skills training model might be difficult. DBT-informed treatment is not something that is evidence-based, and for that reason is not something that I would recommend for high-risk populations. And we're going to talk in just a minute about what types of patients are most appropriate for this type of DBT-informed treatment. It is more accessible and less expensive to implement than standard DBT. And regardless of whether you're using the full program or a DBT-informed model, therapist consultation is still very strongly recommended. So suggested interventions, and I'm noticing on my timeline that to get through all my slides, I'm running a little bit behind already. So I'm going to do my best to move forward through this and not take up too much time with it. It is really important to be matching the patients that you meet with an appropriate level of DBT. So I wanted to take just a minute to talk about who is most appropriate for each of those 3 levels of DBT. Standard DBT is a mode of treatment that is recommended for patients who experience life-threatening behaviors. So these are patients who might have repeated suicide attempts, suicidal statements, or chronic suicidal ideation, as well as non-suicidal self-injury or deliberate self-harm, and other imminent life-threatening behavior. It is also appropriate for patients who have serious therapy interfering behaviors, such as non-compliance with treatment, non-attending behaviors, such as dissociating during sessions or just not paying attention, not engaging, or behaviors that interfere with the therapist's ability to treat the patient. Patients who experience severe quality of life interfering behaviors are also most appropriate for standard DBT. So that would include severe mental health disorders, extreme poverty, deprivation, homelessness, or criminal behaviors with imminent risk of jail, domestic violence, or difficulties controlling their own behavior with serious potential consequences. Patients who have severe skills deficits or significant difficulties regulating intense emotions are also really appropriate for standard DBT. It is important to note that for patients who have PTSD, there is an additional protocol that is evidence-based and recommended for this population that includes standard DBT plus either prolonged exposure therapy or another evidence-based trauma treatment. DBT is not trauma treatment, and it can be very effective in helping to stabilize unsafe or destructive behaviors in patients who have PTSD. DBT is also evidence-based for substance use disorders and eating disorders, and utilizing a DBT protocol for specialized towards those populations is recommended in those situations because standard DBT does not necessarily directly target those behaviors. Skills training only is an approach that is suggested for people who do not meet any of the above criteria for standard DBT, who do experience mild to moderate mental health disorders that are unlikely to respond to treatment as usual without systematic and consistent exposure to new coping skills. So these are patients that might be hanging in there right now, might be kind of silently suffering with things, and who, you know, it's pretty clear that if they're not going to get skills to help them move forward through what they're experiencing, things are likely to get worse for them. DBT-informed treatment is a type of treatment that is suggested for people who do not meet any of the above criteria and have symptoms that are stable enough to learn skills as needed without significant risk of symptoms worsening in the meantime. So making sure that if you're not using a systematic approach to skills training, such as skills training only or standard DBT, that you're pretty confident that that patient is not going to decompensate in the meantime. So I'm ready to move into our first question and answer section. I know I've packed a lot of information into a very short amount of time. Dr. Terrace, I'm not seeing any questions up. Are there any that I might have missed?
No, there don't appear to be any questions at this time. Anybody who has a question, just type into the Q&A box.
And I would certainly also welcome feedback during this time if the pace of the training is going too quickly, or if there's any further focus that would be helpful on clarifying any of the information we've gone over so far in order to be more helpful to people. So the first question we've got up is, would you recommend DBT for middle school students? Absolutely. I first started my exposure to DBT in a middle school day treatment setting, and DBT in its standard format that was designed for adults can be utilized for middle school students, but there's also a pretty fantastic adaptation of standard DBT and DBT skills for adolescents. There is a list of references at the end of this presentation, and I'm pretty sure that I included the reference for the adolescent skills training on that. If I did not, it is by Miller and Rathas, and it can be very helpful in working with middle school students on the DBT skills. Hope that answers that question. Next question is there a suggested resource that has the 3 levels of DBT in a chart form for simple comparison or differences? Yes and no, because the chart that I worked off of to develop what I've presented to all of you did not include DBT-informed treatment. There is in, and I'm looking for my book right now, in the DBT skills training manual, towards the beginning of the book, there is a chart that lists different types of behaviors and suggested levels of care and levels of DBT that are most appropriate for each of those behaviors. So I would certainly encourage you to check that out if you get a chance. That manual is definitely listed in the references at the end of the training. Let's see, one last question. It says, I know there are many school-based mental health providers in the audience. Can you lend some examples and implications for any strategies that can be used? Definitely. So our next section is going to get into some of the individual therapy strategies that are based on DBT. And I would certainly recommend most, if not all of them, for a school-based setting. DBT has been and is used successfully in a number of school and day treatment and inpatient settings. So yes, all of this will be applicable. The last section that we're going to do is on skills and how to practice some of these skills with your patients. So I'm hopeful that those will be helpful for you guys as well. I currently do not practice in a school setting or with an adolescent population. I have in the past, but that's not my area of focus right now. So some of the examples that I have may be a little more geared toward adults, but you're more than welcome to adapt them as needed for work with adolescents and what feels appropriate to you, as well as to check out the Miller and Rathis book on DBT for adolescents. Let's see, I think we're all set with the Q&A phase for the first section of our training today. I'm going to go ahead and move on to our next section. All right, so we are moving into session strategies for DBT. And I want to actually jump back for just a minute. I apologize. In terms of accessing different levels of care in the community for our patients, if you identify that you have a patient who really maybe needs standard DBT or a DBT skills group, and that's not something that you offer, the behavioral tech website, behavioraltech.org, which is Marcia Lenahan's website. She's the developer of DBT, offers a great resource for locating DBT trained therapists and teams across the country. Not all DBT programs are going to be listed there, but it's a great resource for checking out options. Closest to us, the closest standard DBT programs are going to be in Syracuse. Hutchings and Upstate Medical, I believe, both offer standard DBT programs. As far as DBT skills training programs, my understanding is that UHS Outpatient Mental Health may still offer that resource for adults. And DBT-informed care is something that's offered in a wide variety of settings across our community with different levels of training and intensity. I know there are several clinicians still at Lord's Center for Mental Health and in other clinics and settings who are intensively trained in DBT and able to offer either an adapted standard DBT or a DBT-informed treatment that can be helpful to patients. So I hope that's helpful in at least recognizing some referral options for patients as well. So I want to jump into some session strategies and talk a little bit about what to expect from what you're going to get out of this training. So this is not an intensive DBT training, otherwise we'd be here for a lot longer than we're going to be today. And I want to give you guys some options for things that can still be helpful to your practice. The scope of this training is not designed to fully prepare you for providing standard DBT or DBT skills training groups. If you are interested in further exploring those options in your own career, I would really encourage you to check out training options through Behavioral Tech, which is the only provider of DBT training that I'm aware of that most of the insurance companies require training through in order to reimburse for DBT. Skills and strategies that we cover in this training are suggested for use with people who are not currently experiencing life-interfering behaviors and who have a low likelihood of decompensating before all necessary skills can be gained. Our goal is always to connect our patients with the most appropriate level of care. And if you recognize that there is a mismatch between your skill set and your patient's current level of need, this can give you some skills to help bridge that time between you when you recognize that and when you can get them into a more appropriate level of treatment. It is not meant to be a long-term treatment for those patients. There is also very little research currently on the provision of DBT-informed care, and suggestions that I provide in this training are based solely on my own clinical experience, as well as my experience in consultation with other DBT-trained clinicians and other clinicians in a clinic setting in general. They are not based on research or firm data, so I want to underscore that as well. So I'm going to jump in off the deep end and say one of the most important skills from DBT in an individual therapy setting is being able to structure your sessions. Patients coming in can present with very complex and scattered needs and expectations, and being able to have structure to your sessions can really improve your chances of hitting the targets that you want to hit. Being able to start by orienting your patients to all of your expectations in the sessions is really important. The more that you can orient the people that you're working with to what you expect of them, the more likely they are to be able to work with you in working towards those goals rather than working against you or shooting in the dark. So being really clear about what you're hoping to get out of each session, the strategies that you're going to use, and what your most important focus is during the session and why, can go a long way toward getting clear in a really complex situation about what's going to be most helpful. In DBT, we always assess. We take time to assess what's going on before we intervene in an issue. It can be really tempting because there are so many great skills in DBT to say, oh, you're feeling depressed today? Here's a skill that you can use. Let's do this. And if we don't take the time to fully assess what's going on that's leading up to that person being depressed or being fearful or whatever the issue is that they're presenting with in that day, we have a high likelihood of missing the mark on what interventions might be most helpful to them. So making sure that you're taking time that it takes at the beginning of the session to fully assess what's going on for them that week before you jump in with change strategies to help them improve that situation. In DBT, we have an order of priority in which we address concerns with patients. It's not always how we address things necessarily in terms of what we do first, second, and third, but it is the order of priority, and we always make sure to address the first and higher level priorities before the session ends. So first priority in all DBT sessions is always to address life interfering behaviors. With the idea that if someone is not alive, they are not going to benefit from any type of therapy. Hopefully you will have screened patients for whether they're most appropriate to be meeting with you if you are not providing standard DBT to them. And this is something you won't come across. And most of us deal with this regardless of whether this is something that we screen for or not. So being prepared and being able to catch these things as they come up and address them directly is really important. Life interfering behaviors are things that include suicidal thoughts or actions, non-suicidal self-injury, and behaviors with the potential for very serious consequences. Those are always going to be a first target in treatment, and those are things that we're going to orient patients to as we're starting treatment with them, that, you know, hey, this is really important because you can't benefit from treatment if you're not here to benefit from treatment. So if you tell me any of these things are going on, we're always going to talk about them pretty quickly. Our next target is going to be therapy interfering behaviors, with the idea that if someone can't fully engage in therapy, they're not going to benefit from therapy. Therapy interfering behaviors are going to include behaviors of the patient and or the therapist that have the potential to interfere with progress and learning. This can include things like missing sessions, like being on the phone during a session or texting. It can have to do with not completing homework or just not paying attention during a session. Again, not just for the patient, but also for the therapist. And if I'm catching myself doing any of these things during sessions, I'm making sure that I'm calling myself out on it, and I'm modeling for the patient how to make a plan to not do this again in the future, and acknowledging that it does impact their treatment. Next target is going to be quality of life interfering behaviors. So these are the general problems that most people come to therapy for. Situations impacting current and future quality of life, such as depression, anxiety, relationship problems, you name it. And if we've already checked off our list that there are no life interfering behaviors, or we've addressed them and we've addressed any therapy interfering behaviors, then our focus becomes the quality of life interfering behaviors. If we've already addressed everything that the person brought to the session, or everything that's practical to address the session, and there's still some time left, then we're going to take some time in individual therapy to focus on skills. So teaching new skills, and then reviewing understanding of skills previously learned, and discussing application to new situations. Next, strategy from DBT that's really important as a clinician in general is clinician support and supervision. Work with vulnerable populations is really hard. It takes a lot out of us. And being able to have access to supportive supervision is not just important, it is critical, and it is a critical piece of standard DBT. A DBT program that offers all other pieces but does not offer a therapist consultation team is not DBT. Weekly consultation team meetings are held with other clinicians who are practicing DBT and who are familiar with the same concepts. Focus on therapy for the therapist is done during these sessions. So this doesn't mean that I'm going to be talking to my peers about what happened in my childhood or all of the horrible things going on in my life, but it does mean that I'm going to be checking in with them if I'm showing up really sad because there's something big going on for me and I need some help and support processing through something in order to be more present for my patients. It also focuses on case review with a DBT lens. So making sure that I'm holding myself accountable in adhering to the DBT skills and strategies, and especially the ones that might be really difficult to adhere to when patients aren't liking them so much and are actually punishing me for providing that type of treatment. Not everyone wants to talk all the time about what their cutting behavior was last week or whether they're feeling suicidal today. And it can be difficult to have these conversations with people. Holding yourself accountable by getting other clinicians to ask you how you're doing with these things can be really important. Also having some time to reflect on your own behaviors that may interfere with therapy is really important as a part of clinical supervision and peer support. All of us have behaviors that have the potential to interfere with therapy. It doesn't mean we're bad therapists, it means that we're human. And being able to look objectively at how we can improve our own practice and things that we can do that can help our patients to be more successful can really go a long way toward improving our practice. Next strategy that is a strategy from DBT that I find one of the most helpful is the validation strategies. Validation is one of the hallmarks of DBT that sets it aside from a more traditional cognitive behavioral therapy approach. And validation is something that all of us need on a regular basis in order to feel connected to and supported by the people around us. Patients who show up with challenging behaviors, with complex problems, often have a real dearth of validation in their day-to-day lives. And being able to practice these strategies can not only help to improve your relationship with your patients, but can also help them to be more invested and make more progress in treatment. So we have 6 levels of validation that are identified in the DBT model. In DBT, levels 4, 5, and 6 are going to be the ones that give us the biggest bang for our buck. Practicing those types of strategies are going to get us a lot further in terms of patient buy-in and benefit from those interventions than some of the lower level strategies. And all of these strategies are very important to treatment. Level 1 validation is to just pay attention to your patient, to use body language that conveys interest in what they're saying, to lean in as you're speaking to them, to put some emotion behind your voice, and to use eye contact. Level 2 is to reflect back what you're hearing, to objectively repeat back what you've heard, and to ensure that you have an accurate understanding of what they're saying, avoiding a judgmental tone of voice or judgmental language. So summarizing what they're saying using reflective listening skills that most of us were taught in school, and that are also easy to forget in situations that become stressful. Level 3 validation is reading between the lines. This is knowing the person that you're working with, noticing and responding to their body language, tone of voice, and facial expression. Assessing their current behaviors in the context of what you know about them and their history, and listening for things that aren't being said. So this might be something as simple as someone who always comes in and tells you, just so you know, I'm not feeling suicidal today because I know you're going to ask. And today they show up and they don't tell you that. And that omission is reading between the lines. If you can then say, I noticed you didn't bring it up. How are you feeling today? Level 4 validation is conveying understanding, acknowledging out loud how that person's thoughts, feelings, or behaviors make sense given that person's past experiences, current circumstances, and or current state of mind or physical condition. So this is not condoning everything that they're doing, thinking, or saying. This is acknowledging that, you know what, it makes sense that you're feeling sad right now because you just lost a really important friendship. You might not want to validate, make sense that you just punched a wall because you're feeling sad, because that might not be a valid thing to validate, which is what we're going to talk about in a level 5 validation. But that sadness from losing a friendship is something that makes sense and is important to convey. Level 5 is to validate the valid. We don't validate things that are invalid. We do validate things that are valid. So it's looking for the kernel of truth in what's being communicated and acknowledging that out loud and acknowledging the elements in the person's reaction to that situation that fit the facts of their current circumstances. So, you know, I think it makes a lot of sense that you're really mad that your mom changed her mind about whether you could go to the party on Friday. I think that totally makes sense. And again, I'm not going to validate punching the wall or yelling at mom or those types of things if those are not necessarily valid or effective responses to have, but I am going to validate the emotion behind that. Level 6 validation is equality and what we call in DBT radical genuineness. So it's conveying your respect as an equal human being with the other person. DBT is not a hierarchical type of treatment. It is a type of treatment that implies that the therapist is the expert on DBT and therapy, and the patient is the expert on themselves and what their experience is. And both are needed in order to make progress in treatment. So in a level 6 validation, you're going to be honest and respectful about your own thoughts and reactions, and you're going to avoid treating that person as fragile or incompetent. So in this type of a validation, you might do things like give the other person the opportunity to prioritize what quality of life interfering behaviors are most important for them to address during the session. Being clear that you're going to absolutely address any life interfering or therapy interfering behaviors first. It might also be being clear with someone, you know what, I'm really feeling sad that you're so overwhelmed that you can't figure out a different way to deal with this, and conveying honestly what I'm feeling in response to their situation, not in a patronizing way and not in a way that's attempting to make them feel guilty, but in an honest way. On dialectics, and I'm just checking how I'm doing on time here. I think we're doing okay. So dialectics is a foundational skill of DBT, Dialectical Behavior Therapy. Dialectics are the acknowledgement that two things which appear to be opposites can both be true and exist at the same time. And being willing to find a way forward that acknowledges and balances both. So life presents us with a lot of different dialectics. In DBT, some of the dialectics that we identify are the dialectic of validation and change, structure and flexibility, doing too much versus doing too little, and the fact that your environment impacts you and you impact your environment. Helpful way to orient the people that we work with to dialectics is both and sentences instead of either or sentences. So it's not either I can validate you or I can help you work on your changing your situation. It's we're going to work on validation and change. And it can be hard to balance both, and we're going to work together to do that. I want to spend a few minutes talking about the implications of DBT and trauma. DBT is not trauma treatment. It is treatment that can help to stabilize unsafe behaviors and develop a life that people want to be present for, to make work on trauma safe to do. Work in DBT is present focused. if a patient brings up past traumatic experiences, I'm going to address with them the potential for emotional and behavioral impact if we continue to talk about that and address those things. If it's important to continue talking about trauma that a patient brings up because it's directly connected to current difficulties in functioning. For instance, someone had a panic attack last night because they saw something that reminded them of a past traumatic experience. Being able to identify at least the basics of that trauma so I can get an understanding of why they had that response may be important. And I want them to be aware that even talking about it in that small amount can still have an impact on their functioning, their emotions, and their feelings of safety. So I'm wanting them to be fully informed of that before we have that conversation. And I'm wanting to make sure I'm confident that that person has the skills to safely manage that conversation if I'm going to allow it to happen. Details about trauma history in DBT are discussed only as they apply to medically necessary assessments or in direct relation to current behaviors and distress. And in fact, I'm going to orient patients when I'm doing an intake assessment with them that I only need enough information about their past trauma experience to know what's there so that I can get a basic lay of the land. And that it's not because I don't want to know or because I don't care about them. In fact, it's quite the opposite. It's because I don't want to make things worse before we've worked together enough that I'm confident they have the skills to manage that in a safe way. Note of importance is that it has been my experience that people with significant trauma histories typically have a very difficult time with the skills modules of emotion regulation, and I'm losing my place here, let's see, and radical acceptance, which is in distress tolerance. Because both of these skill sets involve aspects of exposure therapy or being present with things that are difficult. Please be mindful that these skill sets can trigger dysregulation, and that it doesn't mean that you're necessarily doing anything wrong. You just want to make sure that the people that you're working with have the skills to manage that dysregulation before you jump in off the deep end. From a DBT model, formal exposure-based trauma-focused treatment is not begun until life-interfering and therapy-interfering behavioral symptoms, again, being suicidality, self-injuring behavior, or any behaviors with the potential for serious consequences, have been in remission for at least 2 months or more. We want to make sure that they are stable with remission from those symptoms before we're starting active exposure-based trauma treatment. And ideally, not until a time that the patient has both internal and external supports for coping safely with exposure-based work. Prolonged exposure therapy is an evidence-based treatment that is recommended by behavioral tech for concurrent treatment with DBT. And it's a mode of treatment that requires significant specialized training. My experience has been that prolonged exposure therapy can be difficult, if not impossible, to implement to fidelity in an outpatient setting because it requires very long sessions and recording of sessions. There are other evidence-based trauma treatments that have the potential to pair really well with DBT, but are not currently really extensively researched as a pair with DBT. And both EMDR and sensory motor psychotherapy are types of trauma treatment that have the potential to be very helpful to people who have already made it through a round of standard DBT. And in terms of session strategies for adult versus younger populations, most of the information targeted in a standard DBT protocol is geared toward adults ages 18 and up. For adolescents, there are specialized protocols, like I referenced earlier, and family involvement is a really critical component of DBT for adolescents, not only in some of the individual therapy sessions, but absolutely as part of skills training, so that the adolescents have people at home who understand what skills they're trying to use and can help them with coaching on those skills when needed. The DBT Skills Manual for Adolescents by Rathison Miller is recommended for skills training for the adolescent population. There are handouts that are developed for younger populations than adolescents that are currently being finalized through behavioral tech, and they are starting to offer trainings for people in using DBT with pre-adolescent children. This is a growing field, and I expect there to be a lot more coming out in the future in this area. All right, so we have some time now to move into questions and answers on our skills and strategies for DBT. First question that I've got here is, are there any trainings available for clinicians? Absolutely. I will tell you that if you go to the behavioral tech website, behavioraltech.org, it lists trainings that are offered across the country, across the world, and they're even offering virtual trainings now. These are the only trainings that are offered by the parent company from Marsha Lenehan, who is the developer of DBT. There are a number of other trainings that you can access for DBT through a number of different companies. My recommendation would be to go to the original source, especially because if you're looking to practice DBT in your own practice or in a clinic setting and need insurance reimbursement, my experience has been that Excellus, Blue Cross Blue Shield at least, is one insurance company that will only reimburse for DBT if someone is trained through behavioral tech. These trainings can be very expensive. They do require a team because DBT is a team-based approach, and they are very time consuming. It is something I would not recommend if it's something that you're just interested in learning a little bit about, because it's something that requires extensive reading, practice, and investment of time, blood, sweat, and tears for this type of training. What I can tell you is that it absolutely pays off in the patient work, and I would not trade the time that I have invested in this training for anything, because I've seen the benefit to the people that I've worked with, and that has been a huge reward. Next question we have is, are there facets or skills of DBT that would be appropriate to use in short-term, brief, intensive treatment or in primary care settings? If so, what and how can we use them? Absolutely. So I guess the first thing that comes to mind for me is being able to structure your sessions and making sure that you're addressing any life interfering or therapy interfering behaviors at every session. The shorter the amount of time you have for a patient, the more important it's going to be to make sure that they are going to benefit from that treatment and that they're going to be around to benefit from that treatment. This training today is obviously not a suicide intervention training or even a training in addressing non-suicidal self-injury. I would encourage you to pursue those types of trainings if that's something you're not already trained in. And I can also tell you that the behavioral tech trainings do offer some really fantastic structured interventions for both of those things. In terms of skills, there are a number of skills that can be helpful for people regardless of the setting that they're working with people in. And being able to help people with the distress tolerance crisis survival strategies, I think, those are what we call the emotional band-aids of DBT. And those are things that can be helpful for anyone to know about, especially if you're only meeting with someone short term. I hope that that's helpful in answering both of those questions. I believe that there is a poll that should have come out to people or is coming out. And I'm hoping you can take just a moment to identify what skills modules you would find most helpful for us to focus on today. My goal is to be able to get through all 4 of them and to spend equal time on each. But I tend to get a little long-winded, and I want to make sure that we can hit the points that people are looking for if we need to narrow down our focus. How are we doing on results from the poll? Okay, so it looks like from our respondents, a little over half of you are really interested in the emotion regulation skills, which we can definitely focus on. I think they are a super important part of DBT, and they're honestly my favorite part of teaching DBT, which my patients without exception groan when they hear me say that, because it's usually not their favorite part. They would rather lock their emotions in a closet and not ever deal with them. And this is the part of DBT that I start to see the most difference for people after work on. I will say that what we're going to cover today in terms of emotion regulation is a couple of high points. It is nowhere near the extent of what's available in emotion regulation. And I would really encourage you to check out the manuals or some of the trainings if you're interested in more information on emotion regulation. Just a side note as well, for those of you who are in school settings or working with adolescents, the adolescent skills training manual is not as in-depth in emotion regulation skills as the adult manual is. So I would really encourage you that if this is an area that you feel that the adolescents that you work with would benefit from more targeted work with than the adolescent manual offers. A lot of adolescents do really well with the emotion regulation skills module from the adult book as well. All right. So let's see. We talked about our poll results. So now we're going to talk about the skills. This is kind of the meat and potatoes of DBT. And this is what most people think of when they think of DBT. So mindfulness is the first section that we're going to start with. Mindfulness is the foundation of DBT, and it is the foundation of all of the other skill sets. When we teach skills in a skills training group setting, we teach 2 weeks of mindfulness in between every other skills module, because it's important to continue revisiting and building those skills. It is also one of the most groan-worthy skills, especially for adolescents, but pretty equally for adults as well, because it feels silly and it feels inconsequential when they practice it. And this is where also being able to identify for people that there is a neurobiological basis to mindfulness, and that practicing mindfulness, which is by definition intentionally living with awareness in the present moment without judging, reacting, or over attaching to it. And I'd also say without pushing it away, that just noticing objectively what is going on both inside and outside of ourselves helps to kick in the prefrontal cortex, which can help to balance the emotional and rational parts of our brains and help us to make more balanced decisions and use more complex skills that can be helpful in the long run. So I've already stated that mindfulness is the foundation of all of the other DBT skills. We cannot practice DBT skills in general without first being aware of what we're doing. Mindfulness skills are skills that can be very difficult to start and then improve with practice over time. They're most easily learned and practiced in very short structured activities, no more than 3 to 5 minutes at a time. And for someone who really struggles with mindfulness, even practicing for a minute can have benefit if you are increasing that incrementally over time. The practice of mindfulness is something that can be done in any situation that we're in or any circumstances that we're under. I can notice what's going on inside of myself or outside of myself, whether I'm standing in line at the grocery store, having a conversation with someone, driving my car, or talking with you guys. Being able to have a specific activity for the practice of mindfulness is meditation. And it doesn't have to be something fancy that only monks do. It is just the practice of sitting down and saying, for this span of time, I am going to practice mindfulness. And there are so many great different ways to practice mindfulness. I would really encourage you guys to do some searches if this is something that you're not real well versed in. There are thousands of different ideas out there on the internet. There are some great YouTube videos for mindfulness, and the scope of this training just really isn't designed to share a huge number of mindfulness activities, but I'm hoping to help with that a little bit today. So one of the most important mindfulness skills in DBT is wise mind. Wise mind is sort of finding your center in mindfulness. It's recognizing that we all have a reasonable or rational part of our brains, a part of our brains that considers the pros and cons, consequences and rewards, and what's right and wrong. This part of our brains is task-centered and goal-oriented, and it focuses on reason and logic. This is the part of our brains that typically ignores those pesky feelings and wants to see what looks good on paper, what's financially going to be a good payoff, what's the best investment of my time. We all also have an emotional part of our brains. And this is the part of our brain that reacts to what does or doesn't feel good. And I shouldn't say just our brains because it involves our whole bodies as well. It's the connection between our brain and our autonomic nervous system that happens when our emotion mind is triggered. Emotion mind can be mood dependent and typically focused on feelings. And it can be influenced significantly by past experiences, social cues, personal values, and may ignore facts, reason, and logic. This is the part of our brain that says, that felt great, I totally want to do that again. Or, oh my gosh, that was the worst experience of my life. I am never doing that again. It's very much based in our emotion. Wise mind is the idea of finding a balance and considering input from both the reasonable, rational part of our minds and the emotional part of our minds. Recognizing that we can't make decisions that are truly best for us if we are not considering both. because otherwise we either end up with decisions that look great on paper and feel horrible in real life, or we end up with decisions that feel fantastic in the moment, and then we look it back and go, what the heck did I just do? So wise mind is that idea of being able to sit with both, consider both, and find a way forward that takes both into consideration. You'll have to bear with me on this example. This is a new wise mind activity that I came up with for this training. But basically the idea here is that the rational and emotional parts of our brain are kind of like the individual lenses of a pair of binoculars. And if we shut our right eye, our emotional eye, and just look through the rational lens, we might only see one part of that winding path in front of us. If we close just our left eye and only look through our right eye in those binoculars, we're going to get a totally different picture of what's going on. So using our wise mind might require that we open both eyes in those binoculars at the same time, or may even require that we put the binoculars down and look at the big picture and not just what we can see through those binoculars. So questions to ask yourself as you're going through a wise mind activity. What are the rational thoughts that you're having about this situation? What are the facts? How do you feel about the situation? And what's a path forward that considers both the rational facts and how you feel about the situation? This may not be an easy answer, and this may not be something that's readily apparent if it's a really complex situation. And orienting the people that you're working with to that is important, because we don't want to imply that complex situations should be easy just because a skill says they should be. Life is complex sometimes, and it can feel invalidating for people to hear, you know, well, just look with both your eyes open, and, you know, the answer should be apparent. Keeping in mind that word should as a red flag is important in all of this as well. And that's something that the people that I work with hear from me a lot, that should is a red flag that there might be some judgment going on. In mindfulness, we're looking at what is, not what we think should be. And we're finding a way forward that balances both. So an example I want to use for this one is, I had the amazing opportunity to have this full DBT training and to develop a comprehensive DBT training when I was working at Lourdes. It was an amazing experience, and it was ridiculously hard work. And I was so excited to be able to help the people that I worked with in that setting. And that was the rational part of me saying, this makes sense. Like, on paper, this is a great thing. And the emotional part of me was saying, I have kids at home, and working in a clinic is a really demanding career to have when you have young children. And trying to balance those two things was like looking through the different lenses on those binoculars. My personal wise mind decision with this was that I needed to work toward developing my own private practice so that I could still practice DBT and be more available to my family. And that was not something that was able to happen overnight. And wise-minded decisions aren't always things that happen overnight, and they're still important. Our next mindfulness skill is objective observation. And this is a fun one. This is one that I really enjoy using with people. So objective observation uses the mindfulness skills of observe, describe, and non-judgmentally. It is just noticing and labeling non-judgmentally the facts about what you're experiencing. So you're describing facts you observe through each of your 5 senses. When labeled as thoughts and feelings, our thoughts and feelings are facts. No one can deny that I'm thinking what I'm thinking or that I'm feeling what I'm feeling. So if I say, I think that it's cold outside, no one can deny that. It's a fact that I think that it's cold outside. Now, 25 other people might have a totally different opinion, or some might agree. And if they label it as a thought, it's a fact, as a thought. Whether or not it's cold outside is actually a judgment, because someone who is in a situation right now where it's snowing might think that what we've got at the moment is actually pretty warm, and someone in Florida might think that this is the coldest place they'd ever imagine being. So getting clear about what facts are and what you notice through each of your 5 senses is important for objective observation. And as you can guess, this is a really important foundation for a lot of DBT skills, and especially for effective communication. Keep in mind as you're using objective observation that if a person who isn't able to see what you're describing can't get a fairly accurate picture of what you're experiencing, you might not be being fully objective in your observations. So the activity that I have here is a close-up picture. This is an image that is magnified a lot of times, and if you Google close-up images, there's some great ones out there, and especially adolescents love this activity. I've met very few adults who don't like this activity as well. The idea here is to look at the picture and objectively describe what you see. It is not the objective to guess what it is. And you want to encourage them through asking, is that a judgment or is that an objective observation, to get clear about how to objectively observe something. So as you're looking at a picture, you might describe things like color, shape, position in comparison to something else, size in comparison to something else, texture, and their thoughts and feelings labeled accordingly. So, you know, I feel kind of gross looking at this picture would be an objective observation. That's a gross picture is not an objective observation, it's a judgment. What's fun at the end of this activity is then to ask, okay, you've gotten some objective observations in. Take a guess, what is it? And get some guesses as to what this close-up image is of. This image, by the way, is actually a close-up image of a strawberry, which I just found really interesting personally. But there are tons of close-up images that can be really fun to do this with. And pointing out at the end of this activity, whether they got their guess right or wrong, that our judgments are sometimes right and they're sometimes not. And, you know, even though we're spot on in our judgments sometimes, it doesn't mean that we always are. And acting from those judgments without being clear about what the facts are can sometimes result in some pretty skewed decision making. Is a really important part of this activity. Distress tolerance skills we're going to move on to now. Just checking how we're doing on the time. I think we're doing pretty well actually. So crisis survival strategies, and these are those skills that I referenced that can be really helpful, especially in a short-term setting, a primary care setting, in a school setting. These are helpful just about anywhere. And when I look to make sure that I feel confident that my patients are ready to start emotion regulation skills and that they're ready to start some of the harder work that may have the potential to trigger them in some ways, I want to make sure they've got a really solid foundation in distress tolerance so that they can self-regulate and safely bring their distress level down when it does go up. Distress tolerance crisis survival strategies, like I referenced earlier, are the emotional band-aids that we use to help get through really stressful situations without making them worse. These skills are not intended to solve complex problems, and in fact, using them to the exclusion of using any other skills can actually make situations worse because it can have the effect of burying your head in the sand while the world goes on around you and not attending to things that you need to be doing. So these are meant to be used in moderation and when needed, not as a fix-all for everything. And explaining that to your patients so that they can know when to effectively use these skills is really important. So our first skill that we're going to talk about is paced breathing. And this is one of the easiest skills to teach, one of the most convenient skills to use because our breath is always with us. It's also a skill that tends to get some eye rolls from people because, oh, here we go with another breathing skill. And this is a skill that is grounded in science. This is grounded in our neurobiological reactions to our body chemistry. So this is a skill that we use to impact our rate of breathing and send a message to our brains that it's safe to calm down, that it's safe to not be on edge, and that it's safe to slow the process and not be as on top of things, because the paced breathing rhythm is a rhythm of breathing that our bodies go into as we prepare for sleep. So the way that we start paced breathing is that we do some counting in our heads at a regular rhythm to determine the length of our breaths. It's something that requires focus, and it has a side effect of not allowing a lot of space in our brains for other thoughts to push in because we're focusing so hard on maintaining that counting. It is also normal when we're having a lot of intrusive thoughts for those other thoughts to push in, and that's okay. That is a part of the process. And when they do, we acknowledge them as distractions, and we gently refocus our attention back to measuring the length of our breath by counting. The point is to make each out breath longer and slower than each in breath. And as I said, to match the rhythm that our body uses as it prepares for sleep. So the idea here is, as I said, to use counting if you're working with someone for whom counting is an issue, someone who has OCD per se, and counting is something that they have a difficult time stopping, or someone for whom counting just doesn't work. They can also, in place of counting, use reciting the alphabet or singing a song in their head if it has a regular rhythm, and they can easily determine how far they're getting to in that song with each in and each out breath. So I'd like you guys to practice this with me today. I want you to take a moment just to get into a comfortable position and notice the sensation of your breath as it enters and exits your body. The idea is to start counting in your head at a regular rhythm, starting at 1, to measure the length of each in-breath and each out-breath. So as your in-breath starts, you're going to start counting up from 1. And then as the out-breath starts, you're going to start counting up from 1 again. And just take a moment to notice the length of each in-breath and each out-breath. Now, without forcing your in-breath to be any shorter or longer than it wants to be, you're going to purposefully make your out-breath 2 counts longer than each in-breath. So if you're breathing into the count of 2, you're breathing out to the count of 4. If you're breathing out to the count of 4, you're breathing out to the count of 6. And just take a moment and practice that pattern of breathing. The idea here is not to encourage the people that you're working with to take great big deep in-breaths, because big deep in-breaths when someone is feeling anxious can have the impact of sending a feedback loop to our brains to become more anxious. It's that gasping breath that happens when we feel really fearful that can send a message to our brain that, see, there is something to be worried about here. We're actually lengthening and slowing the out breath can have the effect of preparing your body for relaxation and feelings of safety as it prepares for sleep. Our next distress tolerance skill that I wanted to talk with you guys about is a newer DBT skill. It's not in the older manuals. And this is a really cool one because it works directly on the chemistry of your body without taking a pill. There are no medical side effects like you would get from a medication. Although, because this does work on the chemistry of your body and a number of different systems within your body, there is an important medical alert to screen for in practicing this activity, that anyone with a heart condition needs to consult with their doctor before attempting this activity. This is an activity that actually slows your thoughts as it lowers your blood pressure and your heart rate. So if someone already has issues with low blood pressure or is on medication for blood pressure, we don't necessarily want to make them pass out. That's not the goal in this. But this is a skill that when used appropriately can have a really rapid impact on agitation level and can help to kind of ground distress level so that we can access more complex skills and find a more balanced way forward. Another side effect of this activity that is important to be aware of is that when used in its original format, which I'm going to talk about in just a minute, this activity can bring on feelings of short-term panic because this involves plunging your face into a bowl of cold water and holding your breath for 30 seconds. And it is very normal to have thoughts when you do this of, oh my gosh, I'm going to drown now. Those are normal thoughts to have. And I personally do not know anyone who has drowned in 30 seconds. And Reinforcing for them the importance of holding their breath while doing this activity is really important. If the panic is too much for them, it is okay to find other ways to use this strategy. And I will talk about some of those other methods in just a minute. Orienting someone before they try this activity that is a potential side effect may be really important, and also keeping in mind that they are the ones in control of how long they do this for, and if they don't feel they can practice it for the amount of time that's recommended, that is their decision. So the cold water tip skill, again, I've got the medical alert posted here. That's a really important point to be oriented to. So what we're going to do is cover the face, especially your eyes, forehead, and cheeks, with cold water by submerging your face into a bucket or bowl of water while holding your breath for 20 to 30 seconds. What this does is it triggers something called the dive response or the dive reflex in our brains. That is a reflex that happens when we dive deeply into very cold water, and it does regulate our emotions quickly. It slows and focuses our thought, and it lowers our heart rate and our blood pressure. We can get benefit without plunging our face into water. I'm personally not a great fan of that one. It feels a little weird. We can get a very similar benefit by using a flexible ice pack or a package of frozen vegetables that can conform to your face, or a cold washcloth or a Ziploc bag full of water that you store in the refrigerator. Just don't forget to pair that with holding your breath for 20 to 30 seconds. And as a side note, keeping a clean Ziploc bag full of water stored in the refrigerator can provide really easy access if you feel that you're likely to have someone in your office who's going to be really stressed, or if someone is looking for a strategy that they can access easily at home. And using a Ziploc bag, especially if it's bagged twice so it doesn't leak, can be a lot less aversive than needing to stick their face in a basin of water. Keep in mind with this that this is not an easy skill to get people to use, and that practicing this when someone is not in acute distress can go a long way toward being able to actually use it when they are in acute distress. All right, we are moving on to the emotion regulation skills. I know a lot of you identified that this was an area you were most interested in. So emotion regulation skills are a set of skills for increasing our ability to recognize, understand, tolerate, and change unwanted emotions. Important to be aware that during times of extreme stress, it may be difficult to use emotion regulation skills because they are by nature complex. Our emotions are complex, and the way that they work on our bodies are complex. If someone is in really acute distress, the biggest bang for your buck is going to be to coach them through using something like the cold water tip skill or paced breathing or another distress tolerance strategy that can help to bring their acute distress level down, and then working with them on some of the emotion regulation strategies. So the first skill that I wanted to talk with you guys about, because there are a lot of emotion regulation skills, and it was really hard to choose just 2 of them to work on, and we don't have time to get to nearly all of them today. But the first one I wanted to talk about were skills for decreasing emotional vulnerability. These are known in DBT as the PLEASE skills, and PLEASE is a really interesting acronym if you ever look it up, because it's not a really intuitive acronym for the skills that we're going to use, but it's the name that it has nonetheless. These are skills for being able to take care of yourself and address your basic needs in order to decrease your chances of becoming vulnerable to negative emotions in situations where it can kind of go either way. So these skills are going to be most effective if you're using them preventatively before a prompting event occurs. A prompting event being something that's going to prompt and have a high likelihood of leading to a behavior that's unwanted or an emotion that's unwanted. So this is something you use before what happens happens. And if you can have these under control, you're going to have a lot more resiliency in situations than you would otherwise. These strategies are able to be used during times of crisis to identify areas where change is possible, and not all of these are possible to address in the moment of crisis. So our acronym for the PLEASE skill, the P is for treating physical illness. That's the P and the L. I didn't make this up, I promise. So taking prescribed medication, taking care of your body, and seeing a doctor when necessary. Making sure that you're not, going, it's fine that I've had this cough for 3 weeks, and I've probably got an infection going on, but who has time for antibiotics? These things impact our emotions. We are much more vulnerable to negative emotions when we are not taking care of ourselves and when we're sick or when we're not taking medications as prescribed. The E is for balancing eating and nutrition. So eating healthy foods in healthy amounts at regular intervals. This can be one of the most helpful things to ask someone who comes into your office or who calls you in crisis. Once you figure out what's going on and you're trying to figure out what to do next, asking them, when was the last time that you ate, can be a really important assessment question. Because 8 times out of 10, my experience has been that when I get a crisis call from someone, or when I have a patient in crisis in my office and I ask them, when was the last time that you ate and what did you eat? They say, well, I had some cookies for dinner last night and I really can't remember when I ate before then. And that's automatically going to trigger a lot of emotional responses in us that we would not have otherwise, as well as decrease our resiliency to valid crisis. So being able to offer someone like some crackers or some, do you have a granola bar that you can eat? Coaching someone to make a sandwich if they're in crisis, and they have time to do so, can go a long way toward improving their thought process. The A is for avoiding mood-altering substances. So alcohol, caffeine, and illegal drugs. These can be things that we sometimes forget to think about because, someone presents for counseling, they're not here for drug treatment, right? So why would we think to ask about these things? Well, these are things that impact everyone. And even if someone doesn't have a drug history or an alcohol use history, they may have had 7 cups of coffee this morning or 4 Monster drinks, and that caffeine can absolutely impact their physical experience of anxiety and agitation. So talking with them about identifying what you're dealing with and what to expect in terms of when those substances might wear off is important. Also, some coaching on not using those to begin with and finding safer and healthier coping strategies is obviously really important. The S is for balancing sleep, getting enough but not too much. So, recognizing that around 8.5 hours is the recommended amount of sleep. And that's not what everyone needs. And those needs change with each phase of life and our own personal circumstances. So knowing your patient here and knowing what they need and what they got is important, as well as doing some problem solving with them for making sure that they can get some sleep the next night. The E is getting enough exercise. So trying to incorporate movement and exercise every day. When we go through stressful experiences, it stores cortisol in our bodies, in our major muscle groups. And when we don't exercise to get rid of that, it builds up over time. It contributes to vulnerability, not only to negative emotions, but also to medical illness and disease. So I've given you a play skill inventory here. Questions to ask yourself, questions to encourage your patients to ask themselves as they're identifying how to buff up on their play skills and how to also identify what needs more attention. So asking yourself, when was the last time I ate? Did I eat something that included protein? And if I need it, what's available to me right now that might help me to kind of stabilize my blood sugar and give me the mental energy I need to process through this? How much water have I had to drink today? Am I hydrated? Dehydration can absolutely impact mood. It can impact headaches that impact mood. It can do a lot to impact a number of things in a negative way. And can I get a drink of water if I haven't had one yet? How much caffeine have I had today? Would it help to cut back? Talking with people about a plan to maybe, try going to decaf after 2, 3 o'clock in the afternoon, or, making a plan to find drinks that they enjoy that don't have caffeine or have lower levels of caffeine than what they're currently drinking. Because even if they feel that it doesn't impact them, their nervous system is still being affected by it, and it still can impact their experience of stress and emotion. Have I had, or do I plan to use any alcohol or substances today? If I have, when is it likely to wear off? Because I probably shouldn't be making any important decisions until that happens. And what can I do to stay away from it in the future? What replacements for use can I find? Instead of going out for a drink, can I call a friend on the phone, or can we hang out and talk and not order drinks? How much sleep did I get last night? Was it enough? If not, I might need to be aware that today's going to be a little bit of a rough ride, and that tomorrow might be a different story if I can make a plan to get things in place for a better night's sleep tonight. Am I feeling sick? If so, is there something that would help with it? Have I taken my medications as prescribed? If not, what's a safe way to restart them? And making sure that if someone's been off their medication for a period of time, that they're checking with their doctor and not just restarting automatically at the dose that they were at if they're not sure it's safe to do. Do I currently have an illness or injury that requires medical attention? If I do, what can I do to get help? And making sure that if there are barriers for the people that you're working with to getting appropriate medical attention, that you're taking the time to problem solve with them about how to access the care that they need. And finally, have I exercised at all today? What can I do to build more movement into my day? And keeping in mind that exercise doesn't have to look like going for a run or lifting weights or going to a yoga class. Exercise can look like, taking the stairs instead of taking the elevator. Exercise can look like going for a walk when you get home from school before you sit down in front of the television. It can look like, doing something in the commercials during a program or in between YouTube videos, rather than just sitting for hours at a time. So that's the please skill inventory. The other emotion regulation skill that I wanted to talk with you about today is being able to identify the purpose of our emotions. So keeping in mind that our emotions have a purpose, as much as it seems like they probably don't, and they were just put on this earth to annoy us. And ignoring our emotions should be done at our peril. Emotions that are not adequately acknowledged, addressed, and problem solved for usually get bigger and more intense, not smaller, because of the purpose that those emotions serve for us. So being able to identify what purpose those emotions are serving can help to increase our acceptance of those emotions and also our ability to tolerate them. So I want to identify that we all have 3 functions that our emotions play, and these functions can change depending on the circumstances. We can experience all of them at the same time, or 1 or 2 of them might be a bigger priority than the others. But being able to really identify what those purposes are and checking the facts with yourself about what's going on and what it might be there to tell you and what's feeling important is a really critical piece of being able to understand where those emotions are coming from and what to do about them. So the first function, and this is in no particular order of importance, is to alert you yourself to something important that's going on so that you can check the facts about it. So this might be something that seems like it might conflict with your values, something that feels unsafe. This might be something that is really exciting and feels like it might be a really good opportunity for you. Your emotions are emotions, and they are not facts as they exist outside of your body. They're there to alert you to things. They do not mean that those things are definitely happening, which is why I say that those emotions serve the important function of getting you to check the facts and not just believe that, I think this is a good thing, so therefore it definitely is, because it may and it may not be, and we don't know until we check the facts with the rational part of our brains as well. Next purpose of emotions is to motivate us for action. So in circumstances where we normally wouldn't have the motivation to do things that we need to do, our emotions can absolutely motivate us for action. If I'm walking across the street and I look up and I see a bus barreling down at me, that fear that I feel in that moment is going to motivate me to hightail it across the street as quickly as I can. Most days, I don't make a habit of running across the street. And, especially if I'm not wearing the right shoes to do it. But that fear is going to motivate me to get out of that situation as quickly as possible so that I don't become a pancake underneath that bus. The last, and certainly not the least purpose of emotions is to communicate important messages to others. And what's really important to know, not just about the communication piece, but about all 3 of these, is that the more important that we are perceiving the situation to be, the more critical it is to us, the more difficult it becomes to change the emotions and to hide the expression of the emotions attached to them. So if I'm in a situation where I'm not really invested in the outcome, and I'm not crazy about what's going on, but it doesn't really matter to me, I'm going to have a much easier time keeping a poker face about that situation than I am if it's something that's going to impact directly and I'm super not okay with it. My facial expression, my body language, my tone of voice are all going to change based on my emotional expression in order to communicate what's going on for me to other people. So being able to identify the purpose of emotions, I've identified some questions that can be helpful in doing this. What emotion am I feeling right now? In the DBT Skills Training Manual, in their handouts and worksheets, they do a fantastic job of breaking emotions down into 10 separate categories. And they can be great handouts to use with your patients. They're some of my favorite ones to use because a lot of times you get answers like, I'm upset or I'm stressed. And while those are states of being, they're not emotions. And stressed can be angry, stressed can be fearful, stressed can be sad. And each of those emotions is going to communicate something different to us. So being able to identify what we're actually feeling as far as an emotional category is very important. Is there something I'm having the urge to do when I feel this way? And would it be helpful in this situation? So this is hitting that mental pause button and saying to yourself, is this going to be a great idea? Is this going to help or harm this situation? This is going back to that wise mind skill and finding balance between emotional and rational before moving forward. Asking, is there something going on that feels unsafe, conflicts with my values, morals, or goals, or feels important? Would doing something about it be important to me or something that I care about? These are important questions as you're trying to parse out what these emotions are trying to tell you. And is there something important that I need to communicate to someone, or is the way that I'm communicating being effective right now? Paying attention to our emotions as we're doing these things can be really important to make sure that we're not missing red flags for things that may actually be a big deal in the situation that we're in. Now, I want to pay attention to the time. We haven't been able to get to the interpersonal effectiveness skills, and I want to make sure that we're leaving some time for addressing questions at the end of the training today. I'm just going to peek real quick and see how many questions we've got for the end of the training. And let's see, it looks like we've got a great comment on a book called Breath, the New Science of a Lost Art on breathing techniques. Thank you so much for sharing that. I will definitely check that out. And we've got a question about the difference between a prompting event and a trigger. I'd like to address that quickly, if that's okay. And then if we've got time, if people have more questions, let me know. Go ahead and put them in. If we have a few more minutes, I will do as much as I can with the interpersonal effectiveness skills before we need to wrap up for today after I address this question. If there are skills that I don't have time to get to during the training, you will have access to the slides in order to check things out on your own. And if you have additional questions, my contact information is listed at the end of the slides, as well as the resources that I've referenced. And you're more than welcome to reach out to me if you have additional questions. So prompting events and triggers can be used interchangeably. Triggers are usually addressed as things that prompt a negative emotion or an unwanted behavior. In DBT, we use the phrase prompting event instead because trigger usually implies that once a trigger happens, the consequences of that trigger are out of our control. Or they're just going to happen because that trigger has been pulled. A prompting event implies that there's something that goes on that's likely to lead to a certain response that's unwanted, but that there are opportunities for intervention along the way that can prevent that prompting event from turning into an unwanted behavior. I hope that that's helpful. So just in the few minutes that we've got left, and I'll check in when we're 2 minutes out just to make sure there's no more questions. The interpersonal effectiveness skills are skills for identifying your priorities and communicating them as effectively as possible to others around you. What's really important to keep in mind with the interpersonal effectiveness skills, as well as any of the other DBT skills, is that you are only in control of your own behavior. And any of the DBT skills, interpersonal effectiveness skills included, are never going to guarantee that you have absolute control over the outcome of a situation or over the actions of another person. These skills just make it more likely that you can deliver your message as effectively as possible and increase your chances of a positive outcome. So, excuse me, in this regard, I wanted to talk about the DEAR skill, which is the foundation of the 3 different communication skills in DBT. DEAR is an acronym, and many of you who are familiar with DBT skills may have heard of the DEAR man skill. There is also the DEAR skill used in regards to the DEAR give skill and the DEAR fast skill, depending on your priorities. The DEAR skill is a way to effectively communicate to others, regardless of what your priorities are, on what's going on and what you're asking for. So the D stands for describe, and that's using your objective observation skills from mindfulness to describe facts about the current situation in order to orient the other person to the exact circumstances that you're referencing. So for example, I noticed that you finished off the bottle of juice in the fridge and you didn't put another bottle in last night. So that's the describe skill. Express is to communicate how you feel about the situation. Express your opinions and don't assume that just because you've described the circumstances that the other person will automatically understand your opinion. So you're going to use I statements instead of you statements, and make sure not to make assumptions. So when you don't put a new bottle of juice in the fridge and I have to drink warm juice in the morning, I feel really frustrated. The A is for assert. So be clear about what you're asking for or saying no to. Don't assume that they will be able to read your mind, and don't get bogged down in thoughts that they should automatically understand. Remember that being clear about what you're asking for or saying no to is being kind, even if it's uncomfortable. So I'd really appreciate it if you could put a new bottle of juice in the fridge when you finish one. And then reinforce is the R, and there's some great DBT strategies on using behavioral strategies for positive and negative reinforcement that can help with the reinforced skill if you're interested in looking into those further. But to keep in mind that your actions and reactions can have an impact on others' future behaviors. So making sure not to punish behaviors that you're looking to increase or reward behaviors that you're wanting the other person to stop. So being kind and saying thanks when that person is putting a new bottle of juice in the fridge, rather than making sarcastic comments about, you know, it's about time you finally did that. It looks like I'm not going to have time to get to the final couple of slides. I've given you an outline of how to use the DEAR skill. The priorities in interactions with others, I want to encourage you to take a look at and to keep in mind that this is a metaphor that I like to use. This is not a DBT metaphor. This is one that I've come up with myself of relationships being like a three-legged stool. And that each leg of that stool is like one of the priorities that's present in every interaction that we have, because every interaction includes needs and goals, a need for self-respect or how we feel about ourselves after the interaction, and a need to strengthen the relationship. And if we're not attending to each of these in balance over time, our relationships are not going to be sustainable. So I'm just looking, and it looks like there are no additional questions at this point. I want to really thank all of you for participating in this training today. I've really enjoyed being able to share some of my favorite things to talk about with DBT, and I hope you guys enjoy the rest of your day.
Thank you so much, Nicole, for that excellent presentation. Great information. To the audience, you will be receiving a short survey after the session, and we would greatly appreciate your feedback. And on behalf of Care Compass Network and the Regional Trauma Informed Care Network, thanks so much for joining us today. Have a great rest of the day.
Thank you.